Hello, everyone, and thank you so much for joining us for Conversations in HIV, Patient Voices Guiding Physician Choices. During this segment, we will be discussing one of my patients, a 40-year-old male living with HIV who has multiple health issues. I'm Dr. Meredith Clement, Associate Professor of Infectious Diseases from Louisiana State University Health Sciences Center in New Orleans, and I'm very pleased to be joined by my colleagues, Dr. Nyaku and Dr. Wall. So I want to start by introducing my patient. He is a 40-year-old gay man. He is Black. He is living with HIV. He was diagnosed 11 years ago, and he is now on a stable regimen, bictegravir, TAF, and FTC. He has been on a few regimens over the past decade or so. So initially he was on a boosted L-vitegravir regimen along with TDF and F. And then he was switched to TAF, L-vitegravir, cobicistat, with emtricitabine. And that was really just because the newer regimen came about, not because he was having any issues with that regimen. And then finally, about 6 years ago, he was started on what he's on now, and he's continued to do well. However, he's had some comorbidities that have developed over time, which we can talk about. But first, I want to listen to him talk about the day he was diagnosed with HIV, because I think that was a very impactful moment for him. So we'll listen to him now discuss that.
I was diagnosed on November 23rd, 2013. I remember that day like it was yesterday because it was life altering. At the moment, I felt that it was life altering in the most negative, in the most demeaning of senses that it could be. But my mother, my sister, and my grandmother gave me the tough love and the advice, and as well as the empathy to know that I wasn't in it alone. And that first appointment was so unfamiliar because you're entering into so many uncharted areas and so much uncharted water that you don't know if you're going to make it out of this or if you're going to be one of the ones that succumbs from this. And in those moments, that's where I built up the empowerment to seek and ask the important questions to my doctor. We as African Americans within our community are presented with so many health disparities already. It's empowering when you can empower yourself, but it's also even more empowering when you can empower someone else to ask those needed questions to their health provider and get that dialogue going, because it makes a difference. It makes a difference of life and death.
I just want to talk for a second about when our patients come to us for their HIV care for the very first time, that diagnosis. What is your approach? How do you start that conversation? The things you say to your patients to kind of reassure them. What does that conversation look like for you?
So the moment somebody's coming in having been diagnosed with HIV, or to follow up on their test results to see whether or not their HIV diagnosis has been confirmed, is such a critical part of establishing kind of the trajectory of how they understand what it means to be now living with HIV. And that is, even though that represents a very difficult conversation, for me, that is the time where I'm maybe the most energetic about establishing the relationship with the patient, because I do feel that that is a time where we can be very hopeful. And so oftentimes I thank patients for getting tested, because getting tested can be very difficult. I thank them for coming, because following up to find out what the test results can also be very difficult, because that's very scary. And then I let them know that because they were so brave, in spite of all of these things, now they're going to be okay. Because once you're armed with the knowledge, right, once you have that information, that's really what is necessary to be able to take control and ensure that their health continues to improve.
Yeah, no, very, very similar. I'm very concrete in saying, because I do try to picture what it must be like to hear something like this, and any of us should put ourselves in people's shoes when we think about medical issues and health issues. So first thing I get out of the way is this is not going to kill you. Mm-hmm. You're not going to die from this. My goal is to work with you and see you get gray hair, see you walk with a cane, get you to your first heart attack or whatever it is, because you got to die of something, but it's not going to be HIV. But you have to basically work with me. You have to listen. You don't have to listen to everything I say, but I'm your medical advisor. I'm here to give you advice. I'm not going to tell you what you must do. I'm going to tell you what is the best thing for you to grow old. And we could do this together. It's a partnership.
Yeah. And I actually usually introduce you equals you, undetectable equals untransmittable at that visit too, because I think in addition to I am not going to die, people also want to hear I have a chance of living a normal, healthy life, right? And so he had that first diagnosis visit. He quickly became engaged in care. I think we were really lucky for him that he, as somebody who has fits in kind of multiple different populations where medical mistrust can be present, right? He's African American, he's a gay man, he was younger at the time, where medical mistrust can be at play. He actually put his full trust in us, in the health system. And so I do want to hear a little bit about that too.
For me, it was very easy to trust in the system because of the research I had did with the modernacy in medicines and just the change that we were in where it affected and it pertained to HIV. The advice I would give to someone with the diagnosis who is having difficulty in trusting the medical professionals is that you have to, just like we have our own beliefs and our belief systems. I believe the medical professionals are little angels put here on earth to do the little extra handy stuff that God can't physically do down here for us. So I would just give them that advice. And with giving that advice, again, the key word that I always stress to anyone is empowerment. When you have knowledge, you can empower. When you can empower, you can change. And when you can change, you can take control of your whole life and control of your health.
Okay, great. And so maybe we can talk a little bit about the medical mistrust that sometimes our patients have and how we approach that and how we, kind of try to work with them over time to build rapport and build those relationships.
I think that if a patient is expressing that they have reservations, they've had negative experiences or had family members, friends, see things on the news, that it really ends up being a critical point for me to really take a step back and just listen. Just continue to listen to understand where this person is coming from so that I can figure out what is it that I'm able to offer. Because the person is here, they're with me in this clinical visit, so they definitely want something. And so really listening to what it is that they have as their priorities as well as their concerns so that we can set an agenda that is mutually agreed upon so that we can move forward. And I think that honoring that, respecting that, and allowing and encouraging the patient to really set the agenda for their health care so that they come back and continue to come back. And then as we go through the process of providing education, then we're able to incorporate some of these other elements and then really address or make sure to also really kind of comprehensively address their HIV management and weave that into the whole kind of healthcare agenda.
Right.
Yeah, so I think that's right. So, trust is earned, it's not a given. Yeah. And so I think from the moment this person walked into the clinic and how he was received by the people at the front desk and the person who took him back and checked his vital signs and blood pressure and how he was dealt with even before he gets to see the clinician are all formative and set the groundwork for the future. And I think that helps. This person and your patient, I would tap totally into the strong women in his life. He clearly has reflected on that. They're his backbone. They're the source of strength and support for him. we know what they would want for him, and I have to be aligned with what they would want for him. And I think together we can get him to where he has to go. And he's there. He's engaged. He's all in.
Well, and as I listened to him talk about his first visit, I kind of thought, gosh, he's so brave. Yeah. You know, that was my immediate, you know, he's so brave to come in and just be ready to go. But I think having that support in his life, those strong women, I'm sure that's played a huge role. How about your patients who don't have support systems? Because sometimes I encounter this, right? It's so, you know, I try to talk to a lot of my patients, like, do you have family support? Have you disclosed your diagnosis to others? And I do occasionally have patients who say, I haven't told a single person about this. This is what I live with every day, but I haven't told people. And so what do you offer those patients?
So I think like what Dr. Wall said about tapping into the patient's support is very important. And that support ultimately is what is their community. And so there are times when we have situations where patients don't feel that they have a community that they're able to access, that will be accepting and supportive. And so I think that in our clinics, having community health workers or peer educators, however that role is kind of identified in your health system, is very critical, so that they know that there's another person that is living with HIV who has been down this road of finding out, having worries, having concerns, and here they are now, and kind of, we'll say, on the proverbial other side of this, and that ends up being very critical.
It's really great.
Yeah, I work in a clinic where the vast majority of our clients are rural, and so there's no public transportation. There's no, you know, so for us, there's sort of limited traction for community-based organizations or peer support groups. People are pretty isolated, oftentimes geographically and physically isolated. Yeah. So for us, and for me, I think of it as, well, we're the oasis in the desert. We're a place where you could come here, be yourself, be honest, not be judged, and be welcomed. Yeah. And so that's what we try to cultivate. I don't know that we always get there, but that's the goal. Yeah. And certainly personally, that's what I try to do. Here's a place where I think you can hear and be heard. And then I think people do take that back. That day that you're hesitant, should I take this pill or not? Do I really want to skip today? Or I think they think back to that clinic visit, to our clinic, and picture what we're thinking. And so that's portable and that stays with you. You know, no magic wands. I can't fix loneliness. I can't fix isolation. You know, I can't fix our healthcare system or our social safety net. But we're here. We're on your side. And I think knowing that alone could be really supportive.
And I think that really speaks to just the pervasive stigma around HIV that still persists even in 2024. You know, you're in the South, particularly, I think that exists in the South. Our clinic does have patient support groups, so we encourage our patients, but they don't always want to do that, right? And then the other thing I was going to mention is just, you know, the wraparound services in the Ryan White clinics, or even if you're not a Ryan White clinic, you still hopefully can refer patients to psychology, psychiatry, just so they have someone to talk to, right? That, you know, you as their provider, I think, can do a lot, but sometimes that kind of therapeutic relationship with the psych providers goes a long way also.
I think even just the really important part is I think a lot of busy clinicians don't even pay attention to this. So recognizing that, even just understanding and recognizing that this person is living under this pressure and this isolation is key. Whether you can get to a psychologist or not, even now virtual, we're doing more virtual visits with psychology, which can work for some people, is really helpful. But just being cognizant, these folks are oftentimes, so asking, have you told anyone? This is a great question. You don't have to do it every visit. Right. It just takes a few minutes. But have you told, have you disclosed your HIV? Who have you disclosed your HIV to? If someone says no one, you should dive in a little bit and find out, well, why is that? And it shows that there's not support. Obviously, in your case of your patient, he has disclosed to people, close people, and they're a source of support for him. So I do encourage people to think about, is there one person, your cousin who's a nurse, right? Your friend from high school. Is there one person you can confide in? Because I do think it's a lonely existence when you don't have that, and that's really key.
So maybe that'll transition us actually a little bit to some of his other comorbidities. So this patient has long-standing major depressive disorder. We see that in a lot of our patients. His partner had substance use issues. He didn't himself use substances, but his partner did, so he had a lot. I think they ended up splitting, but that was a really big challenge for him for a long time. And then over the course of his diagnosis, he developed prediabetes, hyperlipidemia. And so some of these comorbidities that we see quite often with our patients that we need to learn how to address now in the era of the Reprieve trial, and a lot of the research field in HIV has shifted towards how do we approach these things in our patients? And we have always seen ourselves as HIV providers, but we need to be more aggressive about primary care, primary prevention. And so the Reprieve study was actually looking at the use of statins as primary prevention in patients with HIV. It was folks who were 40 to 75 years of age. I think the median age was 50. They had a low to moderate risk of ASCVD, so I think median ASCVD risk score of 4.5%, and they were randomized to either pitavastatin or placebo, and the results were pretty dramatic. How are you guys applying these results to your clinic, to your patient population?
Yeah, no, so there's a lot there. I think this is really probably, for me, one of the most important clinical trials that have been done in the field that we work in the last decade or so. But I think taking a step back, this gets to one of the initial conversations I do have with folks who are coming in for establishing HIV care. This is a long haul kind of thing. This is a long journey. So I have medicines we could pick from the list. It is even now injectable medicines. Getting your viral load undetectable, easy peasy.
Right.
The harder part is the work that you have to do. It's almost like being an athlete. And again, if you're engaged, you're coming in, you want to do well, and your patient is clearly in that category, let's lay out a plan for how we can get you to do all the things you want to do. Your goals are to live to a ripe old age. Statins are important in the general population, and now we see clearly even in lowish risk people for cardiovascular disease, statins made a difference, and it was everywhere. This is a resounding effect. Yes. It was in men, it was in women, it was in older people, it was in younger people, it was in every region of the world that this was studied. This is clearly beneficial. So to answer your question, I am talking to basically everyone who would have been eligible for this trial. Yeah. I'm telling them about this. I made a little one-page info sheet in basic language that I could show them and just say, this is why I'm talking to you about it. We don't have to start the medicine today, but I want you to think about this, maybe read about it online, and then next time you come in, let's talk about it again.
Yeah, I appreciate that approach a lot. Anything to add, Dr. Nyakio?
So not anything specifically about Reprieve and the findings and kind of the implications for individual level patient care. One of the things that Dr. Wall spoke on about this being one of the most pivotal trials in people living with HIV in the last 10 years, that's kind of the part that I am been really trying to talk to my patients about for these to try and provide better education and help to do kind of subtle stigma reduction, is to say that people living with HIV are of tremendous importance in our society, and look at this amazing study that was done across all of these different countries, all of those things. So I continue.
7,000 people, right?
Exactly.
Over how many years? 6, 7, 8 years? Yeah.
So that, I think, is the part, is so that, because like we said about sometimes our patients can feel very isolated. So to come back and say, look, we have this multi-center trial that had so many people and contributed. So I use this as to say, and you know, that this is a blockbuster study. It's being run on, you know, the front of our most prestigious medical journals, you know, on all of those things. So that has been, I think, maybe a secondary part of the Reprieve trial, that in addition to talking about kind of the individual level patient benefits, I also try and take a step back to just say, like, you know, people living with HIV are, you know, of such a top health priority in our society, and we've had this amazing, you know, advances that are happening and will continue to happen. So that's the part that I can add.
But I think that the other side of this that I think is going to emerge too is the GLP-1 agonist.
Yes.
So GLP-1 agonist, huge topic, right? But I think that's another area where we've seen in people living with HIV data that show this could make a big difference.
Really
Now,
game-changing.
and now I'm not saying everyone should be on a GLP-1 agonist plus a statin, and that's the way to go. Everyone should be watching what they eat and making smart choices, and we don't have to buy a book or join a $100 program. We just have to make some smart food choices, be a little bit more active in our lives, and we can achieve a lot of what we want to achieve. But when we can't, that's when I think statins, and I'll say GLP-1 agonists, which when you can get them,
When we can get them, that's the
have
key,
made
right?
a huge difference for many of my folks, and the
Yeah.
data in people living with HIV is fantastic. So that's another biomedical. You know, in a few years they'll be generic, you know, and all that sort of stuff, and we'll be using them left and right. But that in my clinic, these two things have really made a difference for people who are even further along on the diabetes, hypertension, obesity spectrum.
That is more and more of our patients. And I like, you know, you've focused on these two drugs, but it's still part of this package where we're encouraging our patients to exercise and eat right, eat smart, not stupid. I like that too. But you know, it's still a comprehensive approach. So I just want to thank you too, because we've kind of gone through this patient's, you know, the trust issues, his mental health a little bit, and then kind of the modern day HIV management that we're all dealing with as our patients age, develop more comorbidities, how to incorporate the most recent data into our practice, which can sometimes be a challenge. And so I just want to thank you both for participating and for joining me in this discussion.
Thanks for sharing your experience with this patient.
Yes,
All right.
thank you very much.
So thank you again for joining us for this segment. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios that we will be discussing.